Welcome everyone to our 20th seminar of the Centre of Research Excellence in Aphasia Recovery and Rehabilitation seminar series. I'm Ciara Shiggins, a postdoctoral researcher at the Aphasia CRE and co-facilitator of the seminar series. La Trobe University acknowledges that this event and our participants are located on the lands of many traditional custodians in Australia. We pay our respects to elders, past, present, and emerging, and extend this respect to First Nations people joining us online today. So today we are crossing Australian state borders to Queensland, where we are joined by Dr. Sonia Brownsett and Dr. Lisa Gillinder, who will present on the topic of language and epilepsy, highlighting the reasons for speech and language pathologist involvement. This is the first joint presentation in the Aphasia CRE seminar, and we are very excited to have you both with us today. Before the formal introductions, let's briefly begin by covering some housekeeping. Please be patient with us and technology today because we've recently switched platforms to the Zoom webinar package. Our apologies in advance if we have any more technical difficulties during your viewing. This seminar is being recorded on Zoom and will be available to access along with past webinar videos via the Aphasia CRE website. Just click on the Resources tab. Videos are usually uploaded 2 weeks after each seminar. We also acknowledge that many are facing difficult and uncertain times during COVID-19, particularly our international colleagues. A reminder that the CRE has developed a repository of aphasia-friendly healthcare resources, which is also available on the Resources tab of the Aphasia CRE website. These resources have been sourced from across the world, and you're welcome to use these in your practice. We have recently switched platforms for facilitating seminar questions. We now use the question and answer function on the Zoom toolbar at the bottom of your screen. Enter your question at any time throughout the presentation, but please keep these brief. You will also be able to see questions by other audience members. Like or upvote a question to show those of most interest to the group. Dr. Brownsett and Dr. Gillinder will answer as many questions as time will allow at the end of the presentation. Please reserve this Q&A box for any questions and no comments. Please also engage with us on social media and via Twitter and also on Facebook. Feel free to tweet along using the hashtag AphasiaCRE. Finally, if you haven't already done so, please join us as a member of the Aphasia CRE community of practice. We welcome people with aphasia, their family members, healthcare professionals, researchers and organisations to join the Aphasia CRE community of practice. Benefits to members include a regular newsletter, updates about events and activities, contributions to research, networking opportunities, and more. The CRE is always looking for financial support. If you wish to donate, please see our website for details. And now, I'm absolutely delighted to introduce Dr. Sonia Brownsett and Dr. Lisa Gillinder for their joint seminar entitled Language and Epilepsy, Reasons for Speech and Language Pathologist Involvement. Sonia is an Aphasia CRE postdoctoral research fellow, currently investigating neurobiological predictors of aphasia recovery. She trained as a speech and language pathologist in Newcastle upon Tyne in the United Kingdom, and after a period of clinical work, went on to complete a PhD at Imperial College London, using functional imaging to investigate cognitive control in aphasia recovery. Before joining the Aphasia CRE, Sonia worked as a postdoctoral fellow at both University of College London, developing the ListenIn project, a study which develops and tests a high-dose therapy app using gamification technology, and at the Queensland University of Technology, working on a large brain tumour study investigating the extent and predictors of pre- and post-surgical aphasia. Lisa has a joint appointment as a neurologist and an epileptologist at the Mater and Princess Alexandra hospitals. Prior to her medical degree, she also trained as a radiographer. Dr. Gillinder specialises in the surgical management of epilepsy. She has a strong research focus and is the lead of the major neuroscience and epilepsy research programs. Her clinical studies are centred around improving epilepsy diagnostics, and her pivotal work is investigating a link between seizure, semiology, and autoimmunity. Dr. Gillinder's work was recently recognised by her receipt of the Australian Society for Medical Research Clinical Researcher Award, and she has also received the Women in Technology Rising Star Award. It is so fantastic to have you both here today for this seminar, and thank you so much for giving this talk. Great. The slides are cut up lovely there. And then...
Okay, can you hear us now?
We can hear you perfectly and the slides are perfectly visible. Thank you so much for giving the talk today.
Thank you, Kira. And thank you everybody for joining us. I didn't realise we were the first joint seminar, but that's very appropriate given what we're trying to talk to you about today. And it's really reasons why speech pathologists need to be involved in a multidisciplinary team. And so it kind of makes sense that me as a speech therapist and Lisa as an epileptologist are giving this talk together. A couple of caveats to the title. We're going to talk about reasons why we think we need to be involved in the management of epilepsy, but that's not to say that obviously people, speech pathologists aren't already working with people with epilepsy. We know that there's some fantastic work already being conducted, but what we really want to talk about is the need for more systematic involvement of speech pathology routinely in this clinical population. And also, if you're not a speech pathologist, it's still going to be relevant because it's really about the role that we can play in a multidisciplinary approach, as I just said. So, there we go. We're going to be talking to you about a range of things today. We'll try and keep it brief, especially given the delay. Lisa's going to talk to you a little bit about what epilepsy is and the causes and the types of epilepsy, and then we're going to talk a little bit about the chronic effects of epilepsy and talk a little about epilepsy and stroke. And then we're going to talk again about the treatment of epilepsy, specifically looking at neurosurgical planning. And then to end, we're going to talk about the anterior temporal lobe and why that's important with this clinical population from a research perspective. So I apologise in advance. We are going to use the term aphasia and language impairment interchangeably, but we do use the CRE's definition of aphasia, which is available on their website, and that is that aphasia is a common language-based communication disability after a brain injury, which can affect ability to speak, understand speech, and read and write. Okay, over to Lisa.
And just for a few more definitions, to set the scene a little bit, I'll explain that seizures are a neurologic event or an episode where there's excessive and hypersynchronous neuronal activity that results in clinical expression of seizure symptoms, and that they can occur acutely as a symptomatic type of event, or they can occur chronically and repetitively as in epilepsy. And the definition of epilepsy being that there is a underlying tendency towards having unprovoked and repeated seizures. You can imagine over time that leads to a whole bunch of secondary effects, including activation of inflammatory cascades, which then results in secondary damage and potentiation of further seizures. There's changes at the genetic level and changes in genetic expression and changes in metabolism and all sorts of other effects which affect the cells themselves. Some of those include sprouting of new fibers, development of new connections, and synaptic potentiation, so that seizures beget more seizures, and so the more you have, the more likely you are to have more. And as a result of that, there's structural and functional rearrangements so that the actual network itself is affected and the underlying functions can be affected and become abnormal over time, which you can imagine is really important for patients and their ability to speak and communicate normally. So there are lots of different types of epilepsy, and on the left of the screen there you'll see the ILAE classifications were updated in 2017, and as broad umbrella terms we talk about epilepsy as a generalized condition, and that's usually in the context of genetic abnormalities. They may not be specific gene defects, but some kind of underlying abnormality that affects the entire brain, so that at seizure onset the entire brain is affected simultaneously. And then the other umbrella term is focal epilepsy, where there's some usually structural abnormality in a particular area of the brain which is abnormal and generates seizures, and that can be caused by a wide range of pathologies, some of which can be congenital but many of which are acquired over a person's life, whether it be stroke or traumatic brain injury, inflammation from either infections or autoimmune conditions, and of course brain tumours. And the result of that is when seizures start in one region versus another, we get different signs and symptoms associated with those seizures. So an easy example is a seizure arising from the occipital cortex will cause visual types of symptoms before it spreads to cause other symptoms depending on which area of the brain it affects. Similarly, seizures arising in the Rolandic cortex will cause motor or sensory symptoms, and they can be either positive symptoms or negative symptoms, meaning a loss of function, so numbness, or a gain of function, being paresthesias or tingling. And then when we get to more complicated areas of the brain, we get more integrated types of symptoms, and often things that the patients can feel, but we can't necessarily see just by observing clinically. And then we have different phases of the seizure itself. So preictally means before the seizure occurs. And sometimes patients can complain that that part lasts for hours or even a few days beforehand. It can be precipitated by things like stress or fatigue. Sleep deprivation is a common one. And sometimes patients can have really specific triggers for their seizures as well. And often the family will describe that the patient appears different. Maybe their behaviour changes, maybe they complain of headaches, but there's a definite change in the patient before the actual seizure occurs. Then the ictal phase is the seizure itself. And like I say, that can be combined of symptoms that the patient feels and signs that we can actually see by observing the seizure themselves. Many patients will describe, elaborate intermixed symptoms, but that's really important. And later on, I'll talk to you a bit more about how we can use those signs and symptoms to figure out where the epilepsy is arising from in the brain. And in particular, we can look at the language features that occur during seizures and try and figure out exactly where in the brain might be responsible for that. And then the post-ictal phase, which is the period immediately after seizure, and we continue to observe in that phase different sorts of symptoms as the brain recovers, and sometimes in particular seizures, you can even have fatigue of the cortex or cortical stunning, where patients will have paralysis of various types after the seizure has occurred. And again, that has localizing value. So the semiology is the word we use to describe the signs and symptoms that occur during a seizure. And like I say, they can be really quite diverse, but they're very important for us to figure out what type of epilepsy this might be and which regions of the brain are involved in that. Language in particular is really important, and all the different components of language can be affected, and they can be affected in different ways, which helps us to figure out, would this be a frontal lobe epilepsy versus parietal or temporal? And that also has prognostic implications as well, and we'll talk a bit more about that when we get to surgery later on. And then aphasia, like I say, can occur during the seizure itself, and so interrogation of the patient during seizures is really important, and we'll talk about seizure monitoring as well, but really trying to understand what type of aphasia they have, what deficits they have, to really localize what areas are affected by the seizure. And similarly, that can continue after the seizure, and the way the language recovers post-ictally can have some really important value. But then in between seizures, like I say, sometimes the baseline function can be affected and impaired, and that also has localization value. And we spend a lot of time in between seizures trying to figure out which parts of the language network are affected, to figure out where the epilepsy is coming from, and also predict, if we operate on these patients, will there be problems after surgery.
Excellent, thank you. So I hope that's a nice introduction to epilepsy at a neurology level. And now we're going to start talking about the reasons as to why we think we need to be involved with this clinical population. And the first one is a bit of a cheat because it's not really a reason, it's really stating the obvious that seizure activity is prevalent in many of the people with aphasia that we already work with. You've seen this diagram already. These are some of the typical etiologies that we might see in our caseload. Dementias, TBI, stroke, brain tumours, all of which there is a prevalence of epilepsy or seizure activity. And if you're anything like me, when you're newly qualified and you see the word epilepsy or seizure in the notes or the referral that you receive, then the extent to your consideration of this might have been how you're going to manage a potential seizure and what the best first aid approach for this neurological deficit is. But I think we really need to start thinking about the impact that this activity is having on the brain, and it's ultimately the brain that we're trying to rehabilitate or assess what's going on in terms of language function. And we can look at this in terms of goal setting. So if you imagine a person that's having uncontrolled seizure activity, they may be having 3 or 4 seizures a day, the goals that you're going to set for their aphasia therapy, if it's appropriate, is not going to be the same as someone who's having very infrequent seizure activity. And that obviously links well to participation, and especially if you think about the stigma that's associated with seizures in terms of attendance to clinic, things like service delivery models. We often find with this population that there is a reluctance to come into outpatient clinics, for example, and this is because they can't drive themselves, so they're either reliant on other people to get them there or they're reliant on public transport, and they want to avoid a situation where they might find themselves having a seizure in public. So just reflecting on what the most appropriate service delivery is for the patient that you've got in front of you. And then in terms of prognosis as well, if they've got a stroke, they've got a significant damage to their brain, but if they're having seizure activity as well, that's going to impact on the prognosis that we can make. We're already cautious about making prognoses with aphasia because it's very difficult to make reliable prognoses, but I think this added neurological deficit can make reliable prognosis even more difficult to make. So if we look at seizures in stroke, and the reason I've chosen this as an example is that stroke is the leading cause of epilepsy in adults over the age of 35. Now, the reported incidence of stroke-related seizures does vary quite significantly. So in the literature report, anything from 2 to 67%. So that in itself is an area that we need to try and understand a little bit more of. But there's roughly 2 types of seizure activity that happens post-stroke. We've got what's called the acute symptomatic seizures, which usually occurs within the first week after stroke. And this, you find this in between 4 to 14% of infarcts. Now, importantly, this type of seizure doesn't typically progress to a full-blown diagnosis of epilepsy, and the seizure activity that we see is very much related to the acute ischemic changes that we see as a response to the stroke. But then we've got late seizures as well, which take place at least a week or more after the ischemic event. And these typically occur with between 3 to 10% of infarcts. And these often do progress to a diagnosis of epilepsy. And this occurs due to the permanent structural and functional remodeling of the damaged regions that we see after stroke. One of the largest studies I've come across looking at the incidence of post-stroke epilepsy is really important for us as speech pathologists and anyone interested in aphasia rehabilitation. This was a very big study conducted in 2013 that looked at over 3,000 people with post-stroke. And they defined post-stroke epilepsy as having at least 2 unprovoked epileptic seizures occurring after the acute phase of stroke. And 2 of the important findings that I just want to highlight from this study were that late seizures were most likely after hemorrhagic strokes, cortical lesions, and large lesions. And they emphasised that this was especially the case if it involved the middle temporal gyrus and the superior temporal gyrus, 2 regions that we know to be involved in language function. And then the other finding was that the presence of aphasia was an independent risk factor for post-stroke epilepsy. So we can be pretty confident that the people that we're seeing as speech pathologists after stroke, if we're seeing them for aphasia and not dysphagia necessarily, they are the population that's most likely to experience post-stroke epilepsy. So in addition to the current caseloads that we manage and that are experiencing seizure activity, the second reason is that chronic epilepsy is likely to impact on language. Now, I talked about this with caution because we don't have very much robust systematic evidence to support this, but what we can do is make inferences from other areas of cognition. So Lisa's already talked about the fact that recurrent seizure activity can lead to structural and functional changes, and that can very much depend on the region of the brain that's impacted by the seizure activity. And we also know that chronic epilepsy can impact on a range of cognitive functions, including things like attention and memory. And often when cognition is assessed in some of these studies, language is included, and as we know, as a subset, language is a subset of cognition, but often language is assessed using a unitary task. So typically you would use naming tasks, naming nouns, or verbal fluency tasks. So we can imagine, depending on the region of the brain, that there is going to be some impact of language, impact on language in terms of the recurrent seizures that are happening in chronic epilepsy. And then we've got an additional confound, which is that some of the side effects from the anti-epileptic medications can impact on cognition. Some of the newer medications have less side effects, but certainly some of the older ones, which are still prescribed for people who maybe don't tolerate the newer medications so well or aren't as effective, they can have quite significant side effects on aspects of cognition. And if we recognize that language itself may be affected, but then in addition to that, we know that various other domains of cognition support language function, especially when language is impaired, then we begin to see that there's three groups of people that are potentially affected by chronic epilepsy. We've got the people whose language network, neural network is impaired. And then we've got people who are experiencing the side effects of the anti-epileptic medications, either to their language system specifically or to the cognitive systems supporting language. And then we've got the overlap of the two. So you've got people who are not only potentially experiencing, have an impact of the chronic epilepsy on their language, but also side effects from their anti-epileptic medications. What we don't know, though, specifically about language is whether it permanently impacts on language function, and whether it results in reorganization of language function. And if it does reorganize, then is that optimal, or is it still suboptimal reorganization? We also don't know how lateralization, so whether the seizures are taking place in the dominant hemisphere or the non-dominant hemisphere, how that differentially impacts on language, given that we know that both hemispheres are important for language, even though one is more important than the other. And then in terms of localization, we know there's certain patterns emerge from the stroke populations of impairments that we see within language. And does that exist in this very different neurology with seizure activity? So we need to try and understand that a little more. I've said that there's not much evidence there, but we do have some to draw on that have focused specifically on language. And some of the most comprehensive reviews have been done by this group, Arthur During and colleagues, who did a great systematic review in 2014, looking at language in epilepsy. And they found that 17% of patients displayed a deficit in more than one area of language. And if we think about the aphasia in the stroke population, 30% of people experience aphasia. Although it's not as high as that, clearly it is pretty high. And then scoping review and data mining study that they carried out more recently in 2018, they found that all of these areas listed here have been assessed in the 66 studies that they looked at. But some of the areas of language were much less routinely assessed in people with epilepsy. Naming, specifically noun retrieval, was somewhat ubiquitous with 54 of the 66 studies assessing that, followed by verbal fluency with 28 studies assessing verbal fluency. But then as we look at more complex language skills like discourse production, we've got very few studies that are actually looking at the extent of language impairment. And really importantly, this is, I think, certainly the only study that I'm aware of that has actually looked at people with aphasia's self-report of language difficulties. So they used a data mining technique where they looked at various social media and website data and found that people with epilepsy are reporting and are very concerned with the language difficulties either experienced by themselves or families with epilepsy. And just very briefly, these are some of the language areas that have specifically shown to be involved in epilepsy. So audio comprehension deficits, reading, writing, and repetition. And then much less frequently, these higher level language skills are assessed. But when they are assessed, we see that there's issues going on here. So we've got difficulties with interpretation of indirect speech acts, theory of mind tasks, and conversational and narrative discourse. And then if we look at semantics specifically, semantics is a memory system, but it's so integrated with the language system that it's often difficult to disentangle. But those studies that do focus on semantics have found naming, word finding, verbal fluency, and synonym judgment deficits. So we do have some evidence to suggest that there are problems with language function in people with epilepsy, but there are methodological issues with the evidence that we've got. So often they look at isolated areas of language, so the studies either focus on semantics or theory of mind, for example, or they're very broad and they look at cognition more generally and maybe assess language just as using a unitary task such as fluency or naming. And then, as I've said, there's problems with the assessments used, so whether they're looking at a single aspect of language and whether that's representative of language function, or whether the assessments they used are based on different populations. So often stroke-based assessments are used with this population, and we know that the age and education of the normative data in these stroke-based assessments do not match the population that we're working with epilepsy. Another problem is that they're mostly cross-sectional studies, so we've got very little evidence of what's happening longitudinally. This is something we need to study more. And then there's the usual methodological issues, which are by no means unique to this population, but with issues with sample size and, as I've said already, control groups being poorly matched. And this is the reason why I think we need to be involved more routinely, or one of the reasons is that we need a systematic and comprehensive assessment of language by people who understand language and understand all the different aspects of language that can be impaired. Okay.
So now I'm just going to talk about the different treatment options for epilepsy and how that's relevant to language. So medications are available, and that's the standard of care. About 2/3 of patients will become seizure-free with medications alone, and that's really the goal of treatment. So once they're seizure-free, that's sort of where the management ends. But as Sonia's already mentioned, a lot of these medications have side effects. A lot of them affect cognition and language, so they're really not well tolerated sometimes. And in addition to that, 1/3 of patients won't respond, which means we need to look for different options. For focal epilepsies, which is where the seizures are arising from one particular area, sometimes surgery can be an option. There's lots of different types of surgery we have available, and all of those different types have different risk profiles associated with them. And a really important consideration is, after surgery, what kind of deficits in cognition and language can we expect? Because obviously we don't want to disable patients more than they already are. So it's really important to take the whole picture into consideration and not just completely focus on seizure freedom, because it can have a worse outcome if patients are disabled, even if they are seizure free. There are also some novel therapies, including immunotherapy, which is a particular interest of mine, and also dietary modifications in certain epilepsy types can be particularly useful. But focusing on surgery, the main type of surgery we offer is resective surgery, where we remove part of the brain. There's a lot of planning that goes into that, and it does require a multidisciplinary approach. And we've got quite a large team of people involved in patient care and patient workup to make sure that we've considered all of those different aspects. Lots of different tests are involved. They undergo lots of different scans and EEGs, and we use all of that information and put it together to see whether we've got concordance, to be really certain about, are we offering the right kind of treatment? And there's also a lot of counselling that goes into that to make sure that the patients are aware of all of the risks involved and how it may affect their life, either for the better or for the worse, and to make sure that they're really comfortable with the decision that they're making. Now, there are some other treatment options available. A radiofrequency ablation is something that we offer at the Mater Hospital. It's less risky, but it's also less effective. And there are also devices available. Again, they're often not as effective, but for patients who are not suitable for surgical resection, it is an option that we can offer. Now, in the workup, like I say, there's a lot of information that we take on board, and there's a lot of professionals involved in working up these patients. We use all of the different information, so the patient's clinical background, looking specifically at the seizure semiology and the scalp EEG to make sure it all looks like it's coming from the same area, looking at functional imaging, especially fMRI, to make sure we're certain about hemispheric dominance, but also looking at SPECT scans and PET scans to understand the perfusion and the metabolism of the potentially epileptic area, and then understanding the neuropsychiatry and neuropsychology with a particular focus on language to make sure we understand whether those areas are involved or not. Now, through that process, if we have concordance of all of our data points, then we will offer surgical resection, assuming that the neuropsychiatrist thinks that the patient is suitable for surgery from a mental health perspective. But if any of that data doesn't add up and we look like maybe there could be multiple different areas involved, or we're not sure which area it is, then we use intracranial monitoring to try and figure out exactly where the epilepsy is coming from. Now, you can see in the picture there on the right, the old technique was to use subdural grids. That requires removal of a large portion of the skull and then placement of a 2D grid array over the surface of the brain. You can imagine, with the brain being a three-dimensional structure, a 2D grid array, it doesn't provide much more information than having scalp electrodes on, and it's really difficult to be certain about exactly where the epilepsy is coming from using that technique. But as you can see there, it's also quite invasive and the patients don't tolerate it very well, so you get a very short period of monitoring. The picture on the left is stereo-EEG, which is a technique that we specialize in at Mater Hospital, where we implant electrodes stereotactically, and they're implanted orthogonally into the depths of the brain. So you can sample multiple regions on the lateral and the mesial surface of the brain to interrogate the entire network that might be involved in the epilepsy and really precisely localize where that epilepsy might be coming from to help you plan surgical resection. Now, you can see here in this picture that the technique's been around for quite some time. This is from the original group that developed the technique in the 50s in France. And while that looks like, quite a scary contraption, what you can see there is the patient is awake and comfortable. And so the procedure is really well tolerated, but it also provides us a really good opportunity to interrogate the patient's seizures clinically as well as electrographically, to be really certain that our clinical and our electrographic data is concordant and that we've definitely identified where the epilepsy is coming from. Nowadays, we use a robot and that assists the surgeon. We plan all of the electrodes beforehand, and we have many multidisciplinary meetings to make sure that we've implanted everything in the correct location and to make sure that the implantation goes according to plan. You can imagine these electrodes are quite small, and so even if an average implantation maybe has 20 electrodes, you're only interrogating approximately 6% of the cortex, so you have to be fairly certain about where you're implanting them. And that's why we usually use orthogonal trajectories and we plan them across cortical areas. So you can see there in the picture that even though we've got one electrode, we've interrogated the cortex in multiple locations. That's a schematic of the anterior temporal lobe to make sure we're covering as much area as possible to limit the amount of electrodes that we're using, because obviously the more electrodes you use, the more risk there is. We plan everything on 3D neuroimaging, and we have double phase MRI scans to help us avoid blood vessels, again to limit the amount of risk associated for the patient. Now the patients go to theatre, then they come back to our monitoring ward and they're confined to bed while we reduce their medications and allow seizures to occur. We can use other provocation methods as well. Sleep deprivation is a common one, and some other epilepsies can have patient-specific manoeuvres where they're particularly sensitive to one thing or another, and that can be really helpful to try and bring on seizures and make sure that we don't have the patient on the ward, because for weeks at a time, I think the longest evaluation we've had is about 3 weeks. You can imagine that's quite difficult for a patient, but it's really important to be certain that we've definitely identified where the epilepsy is coming from and we're planning the right surgery. So after all of that, we can usually identify where the seizure starts, where it's spreading to, what symptoms are associated with those different regions as the seizure spreads. So we know, is it just peripheral or is it distal? And does that reflect what we see in between seizures as well, or which parts of the cortex are irritated in between the seizures? So this is a nice example where you can see a seizure, and this is what we call electroclinical correlation. So we look at the EEG recording, and you can see there on the left, all of the yellow markers identify where these electrodes are located. The seizure activity begins, and then we correlate with the different activities and different signs and symptoms that the patient is experiencing through that time to make sure that we've definitely recorded everything that's relevant to planning surgery. And then once we've recorded enough seizures, we do something called cortical stimulation, where we actually apply a small amount of current through the electrodes that are implanted to the various regions that we're interested in. This is particularly important to make sure that the area we think is generating the seizure is actually generating seizures when we stimulate it, and that seizure reflects a normal habitual seizure for that patient. But also something else we can do is called functional mapping, or applying small amounts of current around that area to try and estimate whether removal of that area will affect any eloquent areas. And language is something that we particularly interrogate, especially for temporal lobe epilepsy, which is the most common type of epilepsy that we'll be investigating with this procedure. And that's important to prognosticate, firstly, what's the chances of seizure freedom if we remove this area, but what are the chances we might cause functional deficits after surgery?
Okay, so the next reason is, once we've assessed language and tried to minimise the risk of surgical damage to a language area, that speech pathologist input is needed where aphasia is considered a likely consequence of treatment. And really the point I want to make here is related to the extensive nature of language representation in the brain, and that we know that post-surgical aphasia impacts on many aspects of quality of life, and from other surgical etiologies, we know that the prevalence of aphasia is likely underestimated due to the assessments used, either again because they focus on naming assessments or because it's a stroke model that's applied to the population. And whilst neurosurgical teams endeavoured to identify and minimise this risk, as Lisa's just nicely illustrated, any surgery encroaching on language regions, or even regions that support language, which I think is something that's often underestimated, may lead to some sort of language impairment. And if we think about the classic model that we're all very familiar with of Broca's and Wernicke's area being important for language, Broca's in the IFG involved in expressive language, and Wernicke's area in the posterior temporal parietal region involved in receptive language, and neatly joined by the arcuate fasciculus, the white matter tract that joins the two. So this is something that medics learn about, this is something speech pathologists learn about in all their undergraduate training, but we actually know that language representation is far more complex than that. And this is just looking at language representation. So this review by Demonnet and colleagues back in 2005 neatly showed the very disparate regions of the cortex that are involved in tasks involving language. And then again in 2012, Kathy Price and colleagues looked at the different functional imaging, both PET and fMRI tasks, studies that use spoken and written language tasks. And again, kind of found that the representation is much more widespread, unsurprisingly, compared to the Broca's Wernicke's model that we're very familiar with. So the point here is really that if this is just looking at language alone, any surgery to any of these regions of the brain has the potential to cause some sort of impairment. And then if we consider the fact that language doesn't function by itself and that it's well supported by very many different cognitive domains, damage to the representation of all those cognitive domains can also impact on language function. So in terms of our role in ensuring that risk is minimized, we can be involved in ensuring that language is comprehensively assessed in pre-surgical language mapping paradigms, and that we move away from the idea that language can be evaluated purely using naming and fluency paradigms. And that's before surgery. But then both before and or after surgery, we need to be assessing language more rigorously and using assessments that are particularly sensitive to this population, both so that we can compare post-surgical outcomes to their pre-surgical baseline language function, actually ascertain if there is a deficit, and then to ensure that if there is a deficit, they have access to appropriate post-surgical management, which will most likely involve speech-language pathology if there is an aphasia. Okay, and last of all, we are running out of time, so I'll try and be quick. This is really an empirical reason why we should be involved in this population. That is that epilepsy can be important for us understanding the different regions of the brain involved in language. So a lot of what we know about the different regions' roles in language in the brain comes from cognitive neuropsychology, where we rely very much on stroke-based studies. So this is the idea that there's an intact brain, an intact language system, and there's a sudden stroke that occurs that results in a certain behavioural deficit. So we can make the inference that that region of the brain is important for that deficit. But there's regions of the brain rather that are actually very well perfused. So we don't usually have see strokes in those regions. And one of the regions that remains contentious is the anterior temporal lobe. And this is, as you probably recall, one of the areas that's most commonly resected. So one of the big questions in research is whether this region plays a role in language. We have converging evidence from many different sources that this region is important for language. So in semantic dementia patients, we see a gradual atrophy in this region, which correlates with an impairment in semantics. And similarly, in herpes simplex encephalitis, we see the same pattern. So the majority of the damage occurs in this anterior temporal region, and they also have a semantic deficit. I did say that people don't usually have strokes in this region of the brain, and that's true, but we came across a very unique patient in 2015 who had very unusual vasculature, and he had experienced, as a result of this unusual vasculature, a stroke to this region of the brain. It wasn't specific, it did extend along the temporal lobe, but he presented very similarly to a semantic dementia patient with an emphasis on verbal semantics. And then we've got evidence from functional imaging studies, and what's important here is that these studies usually are PET studies, so that's positron emitting tomography, and I'm going to talk a little bit about that shortly. But these studies, you've got people lying in the scanner doing various language tasks, and there really is a range of language tasks, and we see that this region of the brain is activated or is being used to complete these tasks. And then more recently, we've got transcranial magnetic stimulation, where you can induce a virtual lesion, some people refer it to. And what we see when we induce these lesions is that we can also induce a semantic deficit. However, the epilepsy population is really important for this because when we remove this region of the brain, which we're hypothesizing is important for language, they don't typically exhibit significant language deficits. So this population in themselves is often considered evidence that this region of the brain plays a very little role in semantic memory and language systems. But there are issues with that inference. And the first is that if you actually probe semantics more thoroughly, so beyond the naming task, for example, then we do see subtle impairments in this clinical population, which shows us that the standard assessments being used are clearly not sensitive enough, and we need to be thinking about the types of assessments we use. And then also an interesting finding is that the post-surgical deficits seen in these patients tend to be more severe with people with a later age of seizure onset rather. So the younger population, the younger seizure onset patients have probably reorganized their language system so that that we do see less of an impairment when you resect this region of the brain. And the other reason why people think this region of the brain isn't involved in language is that in functional imaging tasks that use magnetic resonance imaging, we don't often see this region activated compared to the PET studies I spoke about previously. And this has been used as evidence that this region is not involved in semantic or language systems. But there's a very important methodological flaw with that argument, and that is that the anterior temporal lobe sits very close to big pockets of air in the skull cavity, which are our sinuses, and we have a problem with functional magnetic resonance imaging that where we have an interface between tissue and air, we get either signal dropout or distortion. So you can see in the top image of the brain, this is what we call an anatomical MRI, and the arrows highlighting the anterior temporal lobe beautifully, and we can see very nice anatomy there. And this type of acquisition, which is done in MRI, is very much used to look at the anatomy and look at problems that might be occurring in the brain. But when we're looking at functional activation, so this is getting people to complete tasks within the scanner, and in this example we're interested in semantic and language tasks, we use a different sequence, and that's in this second image at the bottom. And this is called an EPI sequence. And you can see here that in the anterior temporal region and the infralateral temporal region, highlighted with the two arrows, and also in the frontal region, you can see this signal dropout and distortion that we get when the pockets of air are interfaced with tissue. And so when studies report that there aren't activations here, that's really more of an absence of evidence rather than evidence of absence, because we're not going to see activations in this region if we're not actually recovering the signal. So some of the problems with the evidence we've got as to whether this region of the brain is involved in language are the standard assessments that we're using are probably not sensitive enough to detect the language impairments following surgery. We've got this methodological issue of signal loss in this particular region that we're interested in. So we need to be careful of interpreting results from studies that haven't corrected for this and report a null result in this region of the brain. And then most of the studies are cross-sectional, so they don't typically look at pre and post-surgical outcomes. And what we really need to do is see what's happening as a consequence of surgery in people before and after. And then again, the methodological issues that we've talked about previously. So sample size, the control groups being poorly matched, particularly with regards to education and age. And again, the sensitivity of the assessments used for this particular population. So we again can be involved in systematically assessing language, but both pre and post-surgically in order to really understand what role this region plays in language. Okay, so the final reason as to why we're going to be involved is that we have unique expertise. We are very good at assessing language, and we can use this to better understand the scale of the problem. And this is where I introduce Aoife, who's a PhD student that's working with Lisa and myself, and Dave Copland and Katie McMahon up here in Brisbane. And she's about to embark on a study where she's going to systematically investigate and characterise language processing in this population. She's a speech and language pathologist, and we're currently spending quite a lot of time working out the exact details of the assessment battery she's going to use. But importantly, she's going to use both the more traditional tests that are being used, but we're going to try and delve a little deeper and see what extent language is impaired in this population and across the different foci. So she's going to be looking at people with frontal, temporal and parietal epilepsy to see if there's different patterns emerging. So in summary, what do we know about language and epilepsy? We know that language relies on multiple neural regions, not just Broca's and Wernicke's areas. And for those people that know me, this is something that I harp on about a lot. And epilepsy can impact on any of these regions, most typically the temporal and frontal lobes, which we know already are involved in language processing. Many of the people we see already present with epilepsy, and we need to start thinking about how we factor the seizure activity that they're experiencing into their management. And that epilepsy can help us inform our knowledge of the neuroanatomy of language. And as speech pathologists, I think we have a responsibility to try and understand which bits of the brain are important for language. And then also that both pharmacological and surgical treatments for epilepsy can impact on language skills. So it's not just relevant for surgical treatment, but also the side effects that can take place with pharmacological interventions. So speech pathologists know how to assess language and manage aphasia in summary, and that's why we really need to be involved in assessing the extent to which language is impaired in this population. But what we don't know, and what we hope to start tackling over the coming years, is the prevalence of aphasia in epilepsy generally. It's kind of a big question, but it's a really important one. What the profile of aphasia is across the different foci and seizure phases, and does it differ? Are there similar patterns to the ones we see in stroke, or are they very different? And this is a really important one, and I think there is really only one study that's even touched on this, and that is what the patient and family's perspective of any language impairment is. When you see people clinically, they'll often report that they have memory difficulties, and that's not unfamiliar for speech pathologists to hear that their language is related to memory, but when you delve deeper, you do see that it's actually impacting quite significantly on their communication. And then we also don't know what the impact of chronic repeated seizures on language function specifically is. We can make guesses about the impact it's having, but we really need to start studying this systematically. And we think that speech language pathologists are crucial to helping understand or answering these questions. So thank you very much for your time, and thank you to Lisa for presenting with me. I think it really is a multidisciplinary issue, and we need to start being more routinely involved in their management.
Absolutely.
Wow, that was an absolutely fascinating talk. Thank you so much to you both, and thank you for sharing that research, but also giving us an insight into where that research is going as well. You really gave us showed us the importance of that multidisciplinary working, and I think that that is essential if we're to manage people with aphasia, but also those who have epilepsy as well. So thank you so much for that talk. We have a few questions. So Ricky has asked, according to the evidence and clinical experience, when is the optimum time to assess language post-ictal?
Or immediately post-ictal. So usually we have patients that we admit to the ward, and they come in day one. We, like I say, we do some provocation techniques to try and bring seizures on. When a seizure occurs, so we have nurses and scientists monitoring the patients 24 hours a day. So they see an EEG screen and a video screen, and immediately when a seizure happens, the staff go into the room and interrogate the patient. And so they will interrogate them through the entire seizure and through the entire post-ictal period.
Wow. And then he asks, and more importantly, when is the optimum time to commence therapy? When is a patient deemed stable?
Yeah. Do you mean from a medical perspective or a language perspective?
He hasn't specified, or they haven't specified. So, well, language.
I guess from a language, maybe both, we'll do both, but maybe from a language perspective, I think, again, we have to start reflecting on what the purpose of the therapy is, and what type of therapy we're trying to implement, and how those repeated seizures, whether they're well maintained or not, are going to impact on participation in therapy, but also the outcomes that we expect and the goal setting. And I guess from a medical perspective, that would be slightly different. I
think it sort of goes hand in hand. If the seizures aren't controlled, then the risk to language and other deficits is higher. If they're seizure free, then you assume that the underlying problem is resolved as well. So the definition of refractory epilepsy, or when medications are considered to be ineffective, is after they've tried two appropriately chosen medications and they've been increased to a therapeutic dose. So once patients have tried 2 or more drugs, the chances of becoming seizure-free with further medications is 10 or 11%, something like that. It's pretty small. And I think at that point you would start instituting other ranges of therapy and not just medical.
Fantastic. Thank you so much for those answers. We've ran out of time for today, so I'd encourage, if anyone else has any other questions, I'd invite you to contact Sonia, and her email address is on the slide that you can still see. So thank you so much for your participation in our seminar today. Thank you to you, Sonia and Lisa. That was really a fantastic talk.